As you can see from the title, this is a huge topic, right? Sleep disorders and sleep medication. When I go to a 4-day conference, at a sleep conference, this is what we talk about, and we're going to do that in about 20 minutes. So as I tried to think about how to organize this presentation, I decided to do it from a continuum of sleep health perspective. So in 2018, Bicey and Harvey, they wrote a book called Treating Sleep Problems, a Transdiagnostic Approach. And in that book, they talk about an acronym, Are You Sated? That I want to talk about first because it gives us a good idea of how we can evaluate our own sleep health. And if there are providers on the line, it can give you an idea of how to evaluate the sleep health of the people that you work with. So the first, RU, stands for regularity. So this would be going to sleep and waking up at about the same times. S stands for satisfaction. So satisfaction with quality of sleep. Do you feel like you sleep well? A stands for alertness. So are you able to maintain desired alertness without unwanted sleepiness during the day? T stands for timing. So when are you sleeping during a 24-hour day? E stands for efficiency. So are you sleeping most of the time while you're in bed? And D stands for duration. So what is your total sleep time in a 24-hour period? And you can use this acronym, right, in order to determine, okay, well, what about this area? What about this area? How am I doing? And it can indicate areas for improvement or possibly talking with your medical provider to see if there are things that might need to be addressed. So if we think about sleep health, just like most things, it exists on a continuum. So over on the left, we have healthy sleep. These are folks who, when their partner asks them in the morning, how'd you sleep? They say great, and they go on with their day, and they're not tired, and they feel pretty well, and they don't really think much about their sleep, most likely. Next would be disrupted sleep. So these are folks who may not be sleeping as well as usual. It tends to be short-term or maybe minimal daytime consequences associated with the sleep disruption. But essentially, it's disrupted relative to what normal sleep is for that individual, or fairly mild sleep disturbance. And next, we come to sleep disorders. So this is the short list. Chronic insomnia is the most common sleep disorder. Obstructive sleep apnea follows. And then these bottom four are not as common, but they are there and can definitely disrupt sleep and deserve attention. We're not going to talk a lot about them in the interest of time, but they are important and deserve attention, just not today. So, and then we have effective treatment. So they include modifying behaviors. So many treatments for sleep or behavioral type interventions. Treatment of comorbid conditions that might be contributing to sleep disorders or disrupted sleep, and then sometimes medication, and we're going to talk about that toward the end. All right, so if we think about healthy sleep with our acronym, essentially healthy sleep would be consistent sleep-wake times across the 7-day week. So you're not waking up at 6 a.m. Monday through Friday and then sleeping until 11 on the weekends. Subjective sense of good sleep quality. So again, you're feeling like you're sleeping pretty well. You're alert during the day. You don't need a nap. You're not having to, pound caffeine in order to stay alert. You're able to do that on your own. You're sleeping at night, not too early, not too late, not during the day. That seems to be associated with the best health outcomes. And then for efficiency, these numbers aren't included in the definition by Dr. Bicey and Dr. Harvey, but in general, you can figure that if you're falling asleep in less than 30 minutes and you're awake less than 30 minutes during the night, that would be considered pretty good sleep efficiency. And then duration for most adults at 7 to 9 hours. Some need a little less, maybe some need a little more, but 7 to 9 is average. So if we look at disrupted sleep, one of the things to consider is that it's often precipitated by change. And it can be good change, right? It could be getting married or having kids or a change in job that's favorable, but change can disrupt sleep. Travel, certainly international travel or red-eye flights, that can disrupt sleep that sometimes continues for a while. Changes in work schedule or moving from one phase of life to another. You know, people really look forward to retirement, but it can make a mess of their sleep. So it can end up disrupted and sometimes even turn into a sleep disorder. Weight gain can disrupt sleep because it can impact your airway, and we'll talk a little bit more about that. And then any health problems or mental health concerns can certainly disrupt sleep. And then a change in sleep habits or habits associated with sleep. So did you decide to start working out at 5 p.m. after work and you decided to have a pre-workout before that and it turns out it has a ton of caffeine in it? Those kind of things can also disrupt sleep. And then signs of disrupted sleep. So if we go to our Are You Sated acronym, it can be less regular due to shift work or family demands, poor quality. So when you're asked, how'd you sleep? It's like, not so good. I woke up a lot or whatever the problem might be. You're more tired during the day, and particularly in an early stage of a sleep disorder like sleep apnea, you might feel a little bit more sleepy or more fatigued. Timing, you might be sleeping at odd hours due to life demands. Maybe you've had a baby. You could be sleeping at all kinds of times, and that's going to feel like disrupted sleep. Efficiency, you're having more trouble getting to sleep or staying to sleep or getting back to sleep. And then duration is often impacted as well for disrupted sleep. So treatment for disrupted sleep, many times, and I think this is partly our culture, our American culture, but I think it's also human nature, is to reach for the shelf and to find something to take in order to quell the disrupted sleep. But it's actually lifestyle interventions that are going to help the most. So maintaining regular movement, a healthy weight, good nutrition, it's always going to serve you and serve your sleep as well. Coping with any stress that might be coming up, adaptive type coping strategies, making sure that your sleep habits are good. If you're not sleeping as well, you can look at the checklist. So this is kind of sleep hygiene stuff. Do you have a regular wake-up time? Are you using your bed for other things besides sleep or lying there frustrated because you're not sleeping? Are you making sure that you're not having late caffeine or other substances or light exposure that can be stimulating close to bedtime? Is your room cool and dark and comfortable? And then with disrupted sleep, especially in the short term, it's really important not to get too worried about it. It's likely to resolve when the stressor passes or when things stabilize. And it's often that worry about sleep or trying too hard to sleep that then turns things into more of a chronic insomnia disorder. So part of the message here is, don't worry too much about it. If it doesn't pass, then that might be the time to think a little bit more about it. If you are worried or you have concerns or you want to ask questions, talk with your medical provider. Sometimes short-term medication, whether it's over the counter or even prescription, can be prescribed, but the key is short-term. I would definitely recommend these other interventions first. So if we go back to our continuum, we have healthy sleep, disrupted sleep, and then we come to sleep disorders. So let's talk about the two most common, obstructive sleep apnea and chronic insomnia. So if we think about our Are You Sated acronym, obstructive sleep apnea is going to be most impacted, or the areas that are going to be most obvious with obstructive sleep apnea are satisfaction So people are often not satisfied with their sleep, either because they're sleeping poorly or they don't feel refreshed. They're very sleepy during the day often. Timing can get messed up because of napping during the day. Efficiency tends to be lower because they're waking up a lot during the night. And duration can actually be shorter or longer, in part because, if it's longer, it's partly because quality is poor, and so there might be an effort to sleep more. But sleep is disrupted, so it often also leads to shorter sleep. So what are the signs? What are the things you want to watch out for? Snoring, breathing pauses, or waking up gasping or with a snort, waking up a lot during the night, so kind of feeling like you're skating the surface or you never really reach a deep stage of sleep. Sometimes that can point toward breathing disturbance. Morning headaches are a common sign of obstructive sleep apnea. Certainly being sleepy during the day. And then concentration and memory problems, or kind of that morning foggy feeling, or even an all day foggy feeling, that can point to breathing disturbance as well. Now, for a more formal assessment, you can use the acronym STOP-BANG. If you have more than 2 risk factors, you might want to talk with your medical provider. So STOP-BANG stands for snoring, tired, observed apneas or breathing pauses, high blood pressure, and then BANG stands for a BMI of greater than 35, age greater than 50, a larger neck size, and male gender. Now, male gender is a little bit deceiving because once women hit menopause, they're nearly as likely as men to have sleep apnea. So in younger people, this male gender matters a little bit more. But again, if you have 3 or more of these risk factors, it would be a good idea to talk with your doc, especially if you feel like your sleep is poor. And then if we look at treatment, I work with the sleep guys and women, but I also live in the real world. And I often hear, well, gosh, if I go to a sleep doctor, they're just going to tell me I have sleep apnea and throw me on CPAP. Certainly, if you do have sleep apnea, CPAP is often going to be recommended, but there are a lot of other things. So if you do suspect, talk with your medical provider. There will be an overnight sleep study of some kind, either in the lab or maybe at home. And recommendations are going to include things like weight loss, which can impact the airway favorably, exercise, which has independent effects from weight loss on sleep apnea in a positive direction. Some people can sleep on their side, and it significantly reduces those apneas. Now, CPAP or PAP therapy is the gold standard, especially for moderate and severe sleep apnea, so that could potentially be recommended. Oral appliances are useful for a lot of people. In the last few years, there's been an implantable device called Inspire that helps people avoid CPAP if they have a hard time tolerating it. And then researchers are out there working on medications for sleep apnea. So we're not there yet, but there is some promising data, and maybe in the next 5 or 10 years, that will be a potential treatment as well. So a couple things to keep in mind. OSA can look like insomnia, in part because you're waking up a lot during the night. So I would recommend avoiding treating insomnia symptoms like the waking up before an obstructive sleep apnea assessment's been done if risk factors are present. You don't want to treat it with, a medication and then you're kind of sleeping better, but you're still feeling crappy. And then 10 years later, you find out, oh, wow, this was really due to sleep apnea. I should have got it treated earlier. And then whether people are treated or not, I think it's important to use caution with any benzodiazepines or opioids, muscle relaxants, if OSA is present due to the impact on the airway. All right, so if we turn to chronic insomnia and we use our little acronym, it's going to impact all areas of sleep health. So things become less regular, people aren't satisfied, people are tired, maybe not sleepy, but they're tired or fatigued during the day. timing gets messed up, efficiency is poor, and duration is often short. So when you think about insomnia, it really is trouble falling asleep, staying asleep, or trouble getting back to sleep. To meet the diagnostic criteria for chronic insomnia disorder, it has to happen 3 times a week for at least 3 months. But it's often characterized not only by these symptoms, there's other pieces, right? So there's a lot of worry about sleep. People are trying really hard to sleep. They're trying to make everything just right so that they can sleep, but then they can't. People feel wired but tired. People can sometimes describe feeling pretty tired before going to bed, maybe even dozing a little bit when watching TV. But then when they get into bed, they're wide awake and their mind is racing. And then associated symptoms include fatigue, concentration problems, motivation issues, just not feeling like you want to do anything, memory deficits. And so for treatment, first step is to rule out other sleep disorders, right? Like we talked about sleep apnea, for example. First line treatment for insomnia, CBTI, or cognitive behavioral therapy for insomnia. It's a straightforward treatment. It's short and it works. So I would, strongly encourage you to recommend this for the patients that you see, or if you feel like you have insomnia, talking with your provider about where you can find a sleep psychologist or another mental health provider that can provide that treatment. You also want to make sure that comorbid conditions are treated. So depression, anxiety, trauma, pain, a lot of things can go along with insomnia. So making sure that those are treated as well. And then sometimes short-term medication, especially when it's combined with behavioral interventions, is the treatment of choice. So it's not that you never want to use sleep medication. It's just that it probably, you ought to try behavioral stuff first, or at least try them together. All right, so if we turn to medication, I don't know about you, but when I go to the grocery store or somewhere like Whole Foods, it seems like the sleep medication or the sleep assistance aisle seems to get bigger and bigger. There's a lot of selection. You can buy lots of different stuff. With regard to the antihistamines, so these are your PMs, and then, there are a lot sold, a lot of remedies that are just plain old diphenhydramine that are sold under lots of different names. But in general, you want to avoid long-term use. Side effects include morning grogginess. It can worsen restless leg syndrome. So if you do have restless legs, you really want to avoid the antihistamines. And then there have been some studies that have shown possible cognitive decline with long-term use. So these aren't really something you want to mess around with long-term. Now, melatonin is a popular supplement these days for lots of different reasons, one of which is sleep. And you want to keep in mind that melatonin is really a better regulator than it is a sleep aid. So the brain starts to release melatonin a couple hours, 3 hours before your habitual sleep time. It sends the signal to the body that darkness has approached. And since we're humans and we sleep at night, it sends the signal that we ought to be preparing for sleep. So that's the best use of melatonin. And while in higher doses, it can make you a little sleepy, sometimes that can have an impact on the rhythm that isn't necessarily favorable. So I usually will recommend not taking anything higher than 3 milligrams, and usually an hour before bed is better than right at bedtime. Sometimes medical providers will suggest higher doses for specific reasons, and of course you should follow their counsel, but in general you don't need more than 3. You really don't need 3, but I wouldn't go any higher than that. And then side effects include headaches, weird dreams, sometimes nightmares, and then morning tiredness. Now, herbal remedies, there are multiple. So these are some of the more common ones: valerian, L-theanine, chamomile, lemon balm, hops, passion flower, 5-HTP, L-tryptophan, and then some new kids on the block include ashwagandha, turmeric, and if you look at the ingredients on something you can buy over the counter, many times it includes many of these with some melatonin thrown in. And for some people they work, and for some people they don't. If you look at the data, it's very inconsistent. And they're really, at least I haven't found a study that says, look, this is a great sleep aid that's going to work for everybody. So you just want to use it with caution, you know, and just because it works for a family member or a friend doesn't necessarily mean that it will work for you. And you want to be aware of side effects because they do occur. Now, the one recommendation I would give is that if you are taking a medication that impacts serotonin, so like an antidepressant or an SSRI, you would want to avoid 5-HTP and L-tryptophan because sometimes you can get a little too much serotonin, and that might lead to some side effects or an impact that you don't want. So prescription medications for insomnia, there are many. And I think for a long time, this was the go-to. You know, CBTI is more known at this point, but certainly medications are fairly standard in practice. So we have the Z drugs. So this is like Zolpidem or Ambien or Zaloplan or Sonata. Benzodiazepines, including temazepam and triazolam, they both are short-acting. And then the orexin antagonists like Belsomra is kind of a newer player. That would be another sleep-specific medication. Common side effects include drowsiness the next day, complex sleep behaviors. So this is where you hear some of the stories. And then memory impairment, and then rebound, right? So if you take a medication that treats the symptoms, when you stop the medication, the likelihood of symptoms coming back are fairly high. And then there is also off-label use of sedating medications for insomnia. This isn't recommended by, you know, they're not recommended for sleep. They really are just used for the side effect. And these can be sedating antidepressants or antipsychotics. Many of them can make restless legs worse, just like some of the antihistamines, and you're often tired the next day as a side effect from some of these medications. Weight gain can be another side effect. And they really are best used when there's a comorbid condition that exists that ought to be treated with that medication, right? And then if it has a sedating effect and also helps with sleep, it you know, that's kind of a bonus, I guess. So things to consider, you know, again, rebound. If you stop the medication, things are likely to get a little bit worse before they get better or even return to baseline. But it's important to keep in mind that sleep aids can be successfully discontinued. So CBTI is very helpful in that process. Many people are able to come off of sleep medication even when they've used them for 10 or more years. You want to keep in mind that older adults are at increased risk for falls with some of the sleep aids, and so using a lot of caution there. You want to avoid treating something that, you know, treating OSA, for example, with something that's designed for insomnia. You just want to make sure you're assessing and treating the right thing. And then, you know, sometimes, and there is research to support this, that combination behavioral treatments and medication can be more effective than either one alone. So there are folks out there who will need both, and that, you know, I think it's important to have people sleeping well and using judicious amounts of medication. So rather than read through this summary, I'm going to open it up to questions. We have about 3 minutes, and then I'm more than happy to stay after. So I would open it up to Dr. Joy to read some of those questions in the chat.
Thanks so much, Lori. That was awesome as usual. While you've been talking, I've been dropping a few notes in the chat. So that you probably can't see as you're presenting, but maybe I'll just share. I shared with the group that a weight loss of just 10 to 15% can reduce the severity of obstructive sleep apnea by up to 50% in moderately obese patients. So, just reinforcing your comments around weight loss and of course exercise being even an independent effect on sleep.
Right. Yes, and I mean, exercise has an independent effect on the improvement of OSA, but also of sleep in general. Regular exercisers are known to sleep better, although it's not one-to-one. Overall, regular exercisers do sleep better.
There is a question in the chat about the use of magnesium supplements for sleep.
Yeah, so magnesium gets talked about a lot with regard to sleep, and I haven't ever seen a study that says, that it's effective across the board. I think in theory, potentially it could be effective, and certainly if you're low in magnesium, having an optimal level is going to be helpful not only for sleep but for health in general. But as far as from the standpoint of the American Academy of Sleep Medicine, it's not a recommended sleep aid. But certainly if you're low, it would help to have optimal levels.
What about, although you didn't talk about this specifically, Lori, you talked about restless legs, but one of the things I do hear about from patients is leg cramps at night, that end up impairing their sleep. And that seems to get worse as people age.
Right. And that, so, as a medical provider, you guys would know better than I. But I think things like hydration, magnesium in that case, I would check caffeine use, things like that to help with those leg cramps. It is a common problem and does seem to get worse as people get older, and sometimes the best thing to do is get up and walk it off and go back to bed.
There's another question from one of our attendees asking about, you talk about CBTI. Where would somebody find a professional who can do cognitive behavioral therapy for insomnia?
That's a great question, and we are actively working on that. So a sleep center that's accredited by the American Academy is a great place to start. Both the sleep centers that through Intermountain and at the U have providers who can provide CBTI, but there has also been training in Utah for, that people can attend just from the community, or providers can attend in the community. So there are several people out there that are providing it, and we're actually in the process of compiling a list. So I would start with the sleep centers in your area, and then at least the sleep centers at Intermountain are going to have a list of providers in the community or at Intermountain that may not be in the sleep center that can provide that treatment.
A couple other questions. One, and I know we're at time, so I appreciate that there are going to be some people who need to drop off, but if Lori's offered to stay a few minutes to answer questions, please feel free to stay on. Any recommendations around the blue light filtering glasses that people are using, when they're using small screens before bedtime?
Yes. So my reading of the literature is that they are worth it. They do seem to have a real impact, especially when you use them consistently. So the thing to look for is you don't want the filter that people use for the computer during the day. You want a blocker. So you want it to filter at least 98% of that short wavelength of light or blue light that comes off the screen. And you really want to put them on a couple hours before bed if you're going to be on a screen. TVs these days are big. They're big. So then the light that's blasting people from those screens is significant. So I would just wear a pair of glasses if you're going to be on a big screen, or you have to be on your computer or even your phone.
I actually had a patient tell me she was using blue light glasses to help her sleep. She said it had been very helpful. So
Good. Yeah.
my anecdotal experience is the same.
Uh-huh.
A couple other questions. One around, are there any apps that people can use to help them with sleep disturbance at night?
So that's a good question. And there are, there are lots and lots of apps that have things like relaxation or mindfulness. And I think anything that you can build in that will help with a wind down or kind of a buffer zone between your day and when you go to bed are going to be helpful. Some apps recently, I know Calm has, and I think some of the other more popular ones have added sleep stories. You can also find them in podcasts, so then you don't have to pay anything. But some of them are geared pretty nicely. So they start out at one pace and then they actually slow and become a little bit more winding, softer, so that kind of guides a person into sleep. So I haven't ever seen any data that says this is a great idea, but I think intuitively it makes sense. And so there are those apps out there. There's some client claims, right, for like binaural beats and certain frequencies and all that kind of stuff. We may have a better understanding of that in 5 or 10 years, but right now, I wouldn't get behind anything like that.
Okay, I'm gonna. There's many questions that are coming in, but maybe I'll just ask one more and then we'll conclude for tonight. So a question around the use of CBD, cannabinoid products, with sleep disruption.
Yeah. So I get asked that a lot, and the data is just inconsistent. It does seem to help some with anxiety. So if part of what is driving the sleep disturbance is anxiety, racing mind, things like that, potentially it can be helpful. But you just have to keep in mind that there are so many products out there, and you don't know for sure what you're getting. And the studies really haven't been done very extensively. So I think the jury's still out. It's probably not going to hurt you to try it, but I wouldn't, think of it as a cure-all.
All right. Well, Lori, thank you again. Thanks for everybody for staying on for a few minutes as we went through some of these questions. Really appreciate everybody's engagement. Our next Live Well webinar will be in 2 weeks on May 19th. The topic is Resilience Thrive Box, Tools to Combat Stress. Certainly in the midst of our pandemic, that's probably good for all of us. Thank you again for joining. Thank you, Lori, for a wonderful presentation. And everybody have a great evening. Bye-bye.